Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
Thank you very much. So I'm doing something a little bit different today, and we're really not going to talk much about PrEP at all, but I got a question in the last week that related to more of my HIV test and testing experience, and I just wanted to share because I thought the discussion about this question was going to be interesting. So just my disclosures about this talk specifically is that we're definitely going to talk about some non-FDA approved HIV tests, the typical disclaimer for the Mountain West AETC, and this case. So this is the email that I was sent. I wanted to check on a participant, one of my study participants, who had a lab-based HIV RNA that was 238 copies per mil, but the point of care RNA test reported a result of greater than 1,000 copies. The patient reports to the provider good adherence and a fill schedule that matches that adherence. And the question to me, and now to you, I'm going to ask you a question early in our session. How do you interpret these test results? So we have a poll. You have one of four choices based on that lab test of 238 copies and the point of care test reporting over 1,000 copies done on the same day, that one of these tests is a bad test, not reliable. B, this is an example of primer mismatch that I always talk about. C, this is normal. HIV RNA tests, viral load tests can differ in their results by up to 10-fold. Or D, you're trying to trick me, it won't work. So we're going to let you vote. And pretty much across the board. Some greater support for primer mismatch, but this is normal. I'm trying to trick you, maybe. And one of these tests is a bad test. Pretty equal across the board. Okay, let's sort of dive into this a little bit more. So what are viral load tests? So viral load tests are supposed to measure the amount of HIV RNA in blood plasma. And that measurement can come from both actively replicating virus as well as from cells that are dying and are releasing virus particles that aren't able to infect other cells. So I always talk about two-phase decay when people start antiretroviral therapy. It turns out there's actually a four-phase decay. And what you're seeing here, I don't know why they oriented it this way, but on the right figure is days after starting antiretroviral therapy. And on the left is actually weeks. So the graphs look sort of similar, but they're measuring something slightly different. And what you can see is that within the first couple days of starting antiretroviral therapy, active replication really goes away. And there's a very sharp decrease in the measurable viral load. And what my virology colleagues always tell me is basically there's no active replication going on in effective antiretroviral therapy after the first few days, that it's really just about the additional cell populations that as they're dying, they're releasing viral particles. And that's what the viral load is measuring over time, again, with effective therapy. So you're going to see a really sharp decrease in the first few days. It's sharpest with integrase-based therapy. It's less steep with NNRTIs and protease inhibitors, but you can still see, again, on the right, showing days, that in the first month, you see a really steep decrease. And that's when we want to see a couple log change in the viral load. And after that, it's really just about the decay of cells, again, presuming that your viral therapy is working. So again, these viral load tests are measuring not only active replication, but also virus particles. And how do these tests work? Well, there are several different types of tests, which I'm going to show you in a second, but they all generally work through similar mechanisms related to PCR polymerase chain reaction. What you need is the DNA template, so our human cells, and then primers that once the two-stranded DNA is split apart, the primers bind to the two different strands in two different directions and form these small chains that then get replicated over different cycles. Again, there are 3 different types of RNA tests or viral load tests that have been approved over the course of the last, we're at 30-ish years. Most of what is in use right now uses reverse transcription, the RT-PCR, including the ones which our lab uses the Abbott real-time HIV viral load assay, but you probably in various places are using an Aptima quantitative assay, which is also approved for diagnosis of HIV infection, as well as for quantitation of viral load. And then we have previously used the Roche TACMan, and we are exploring another Roche assay right now. But there are other tests, bDNA tests, and these NASBA tests. They all vary a little bit in how they work and what the limit of detections have been. I think for those of us who have been doing this work for some number of years, in the 30 years since these tests came out, the real goal has been reduction of that viral load to the lower limit of detection. So many of these tests have lower limits of detection of 20, 40, or 50 copies, whereas some of the original tests were at the 500 copies per ml level. That's something we're going to talk about a little bit later, though. One of the things I think that's challenging for people is when we think about viral load tests, we really should be thinking about them on a log 10 scale. There are a couple of reasons for that. One is that you can display them graphical form a lot easier. Also, probably most important is that transforming the data in the log scale is better approximate of a normal or a near normal distribution for statistical testing. And then from a clinical perspective, it's changes in a factor of 10 or what I think most of us would consider to be clinically significant. And so a response we can argue a little bit of the semantics about this, but in general, a response from 100,000 to 10,000 is similar to a response from 10,000 to 1,000. Again, I'm going to sort of wave my hands a little bit over that, but it's not that the difference of 90,000 copies is that much more than the difference of 9,000 copies if you are looking at on the linear scale rather than the log scale. So we have to be thinking in log scale, which is really not something that many of us are comfortable doing on a regular basis. And I just try to think of the number of zeros. So 100,000 has 5 zeros. It's log 5 log base 10. 10,000 is 4, 1,000 is 3, so on and so forth. So I want you to just try and let go of a little bit of the concerns about sort of thinking about logs and what it means in between those, because I'm mathematically inclined and I can't figure out logs out of my head. Okay, but that's where we're going to be thinking over the next couple of slides. Okay, so on this slide, we're thinking about primer mismatch. I talk about it all the time, and it is real. And I, interestingly, had a patient back when I was doing work with the UW Primary Infection Clinic who presented in his acute HIV infection with very low viral loads. And what I'm seeing over on this y-axis is his viral loads, again, on log scale. So 3 is 1,000, 10,000, 100,000, 1 million copies. Okay. Initially done by TACMan, and he presented with fairly low levels. This is sort of in the few thousand range. But as part of our work with the primary infection clinic, we were doing multiple assays. And so what I'm going to draw your attention to are these two time periods after infection. And this is over the course of, I think, weeks, that he had by one assay a viral load of a few thousand and another one where the viral load was nearly 100,000. And then again here, this discrepancy of 2 log, 100-fold times different depending on which assay. So primer mismatch is real. There's a lot more concern that primer mismatch is going to impact subtypes that are not clade B, because most of these tests are developed with clade B viruses, subtype B viruses. But I always want you to think about primer mismatch if your viral load doesn't make sense with whatever your clinical scenario is, the CD4 counts are decreasing or someone is clinically ill. So it is real. The other part of this is sort of what do we expect in terms of differences with different tests? And I'm going to show you two examples, but there are lots of these. The first is looking at Abbott versus the Aptima test. Again, two reverse transcriptase PCR tests done in Kenya, so in non-B subtypes, and looking at these are both showing the same data just in two different ways. So this first is looking at Abbott versus Aptima based on these are log again transformed viral loads. So 2 is 100, 4 is to do this 10,000. And you can just see how there is obviously there's a linear relationship between these. It's super strong. The correlation is very, very strong. But not all of these points follow the line. And so really, I think it's more informative to look at this, which is Land-Altman analysis, for those of you who care. So looking at the average of the tests on the x-axis and a measurement that is the difference between the two. And you can see that a lot of them center around 0, meaning that the Aptima and the Abbott gave exactly the same results, but the Aptima tended to report a higher viral load, and that there certainly were, in normal situations, viral loads that were at least 1 log apart, done on the same sample by these two different tests. And I'm just going to show you the same thing looking at the Roche versus the Abbott assays. This is exactly the same, done in the same way. Obviously, it's just the papers did their figures slightly differently. And this one in particular was looking at folks with low viral load, because there's concern that at the lowest viral load, you may get the greater discrepancy in what your viral load results are. And in fact, this is not what they saw. And we'll look over on this right side, the difference actually got greater. So the Roche test was always a little bit higher, and actually the difference got greater as you got out to higher viral loads. Again, these aren't high viral loads. 3 log is just 1,000, right? 3 zeros. But at the lowest viral loads, you actually didn't see the highest discrepancies. When you're looking at a viral load trajectory for a single patient, one of the things, just like with syphilis testing and RPRs versus VDRLs, is that they're going to differ a little bit. And you want to really look at the trajectory from the same test over time, because again, those two tests may differ. This I just thought was interesting. I know, Brian, you talked about viral loads and risks of transmission sometime in the fall. And so I think this paper came out afterwards, which is an editorial basing off a patient who kept seeing that her viral load was detectable, but under 200. And she and her providers struggled with reassuring her that she couldn't transmit the virus, even though her virus was detectable. And so right now, many of you, and I know this is confusing for people, most of these lab tests report in 3 different ways. You can have target not detected, or HIV RNA not detected. That truly means that the test with its sensitivity couldn't identify any virus particles. In most cases, an alternate report in the lab will be under X number of copies, and it's going to differ depending on what your test is, under 20 copies, under 40 copies, under 50 copies. And what that means is that the test identified that there was some virus present in that sample. It just was too low for it to quantify. And then the third one is, of course, you have a viral load that's quantifiable. So that's why there's a number in there. So that's what the standard lab reporting for viral load test results are and what they mean. But this paper argues that there's discordance in what the lab is reporting and what the messaging we are sharing with patients, which is very confusing. And they are arguing that labs should only be reporting things that are clinically significant, because now, again, our patients are seeing their labs and they are getting confused by us telling, oh, you're undetectable and can't transmit, whereas their lab actually says something different. So I think it's interesting, and probably we're just at the start of this conversation about sort of how do we report results? How do we discuss the results? We know that when people have sustained viral loads, I believe above 200 is the standard number that we worry about for virologic failure, although there's concern at levels below 200, 2200, that might predict future virologic failure. And then what copy number is relevant for U equals U, where you've been using 200, but I think Brian's talk argued that perhaps we should be thinking about reassuring people at above 200 that really there's very little risk of transmission. And so I think there's a lot to think about. I just thought this paper that I've referenced below is a really interesting read. And then I just want to open this up because this is a patient who was seen 5 months earlier. She had been undetectable and now she has these results. And based on this, how would you counsel her and what testing would you do? So I'm going to stop sharing and I'm hoping we can have a little discussion with this last question.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.